Thank you very much, all of you guys, for having us here. This is really a special opportunity for me, and speaking on behalf of the panelists, us. This is an incredible moment, to be honest with you. History happened on Saturday. 988, the new crisis line for mental health and behavioral health crisis calls, launched. The last time we had a national line was the 911. And 911 has become something that is baked into almost everything we do. It's hard to know what the future holds for 988, but I suspect that there will be some component of that. And we get to tell you what's actually happening on the ground right now and why a service like 988 is so important. Really quickly, I want to introduce a little bit about Catherine introduced our podcast. We've been around for about 3 years now. We've done 150 or so episodes. I'm just going to read from these notes real quick, forgive me. We do stories like explaining the ACA's so-called family glitch, how prescription drug discount program 340B has evolved, and we've done a story about how big insurance companies that run health plans for large employers called side hustle. Our work has been heard in 25 colleges and universities, which is really exciting for us. So, enough about that. And I really want to introduce this panel here and what we're going to do. This represents the work that Tradeoffs has been doing. We've been interviewing folks for about 8 months now, and the people on the stage with me are some of the voices that are part of the reporting that we've done. And forgive me, I'm just still nervous. I'll get into the flow of this in a minute. But this is a conversation that is going to talk about suicide in some detail, and it's also going to touch on other difficult topics like law enforcement responses to crisis calls. So I want to, before a podcast episode, we'll often give some sort of warning. And this is a heads up to people in the room that this is serious stuff that we're going to be talking about, and I want people to know and understand that and be prepared. A final word before we start. We want this panel to be a conversation, and that's not lip service, where we talk together, not just some people on stage talking at you, sharing wisdom. But to do that, to really make this a conversation, we need your help. We need your involvement. And over the course of the next hour or so, I'm going to occasionally ask, do some informal polling of you guys, and ask for a show of hands. And once or twice, I'm going to ask people to speak up and share a story. Because we really do want, there are a lot of people in this room who've got all kinds of lived experience, and you have something to share too. It's not just us up here on the stage who have something to share, and we really want to make sure you feel like you are welcome to be part of this conversation. That is a goal of our particular panel. So, with that said, again, sorry for my nerves, super psyched, super honored to be here. It's really fun. I want to start by getting a sense of who's in the room. And can you just, with a show of hands, how many people in the room before, obviously, the last 3 minutes has heard of 988? Great. So most people got that background. That's awesome. And raise your hand if you are directly or indirectly involved in making policy, either at the federal level, state level, local level. Okay, a lot of policy making people in here. Great, awesome. And how many of you, raise your hand if you would, have talked with you, part of your job, part of what you do is talking to policymakers? Great. So just so you guys get a sense of who's in this room. All right, finally, last one, and then we're going to dive into the conversation with Carrie. How many people have ever spoken to someone in the middle of a mental health crisis? Okay, all right. So wonderful. We've got a lot of people here who've got a lot of lived experience. This is awesome, and it really is an honor to be in a room with folks like you. Thank you. And what we're going to do, just a little bit, so you got the format, we're going to break this up. This is going to be a little bit less traditional panel. We're going to have one-on-one. I'm going to interview and talk with Carrie one-on-one for about 10, 12 minutes. Then we're going to move to Emily. Then we're going to move to Andrea. And in between these one-on-ones, I'm going to ask questions of you guys, try to get some feedback from you all, and ask for a story or two. So that's the rough thing. Hopefully we'll have some time at the end for some audience questions as well. So with that, let's get into this. And thank you again for having us. So Carrie, let's just start quickly. If you'd introduce yourself, please.
Good morning, everyone. My name is Kerry Brown. I am the Chief Executive Officer for Community Counseling Centers of Chicago, a community behavioral health organization. You probably can guess where we're located.
And so, Carrie, C4 provides a variety of mental and behavioral health services, counseling for kids and families, counseling for adults, sexual assault services, and of course, care for people in crisis. Let's start with this super high-level question. What are 3 of the most common precipitating events that can lead to a crisis?
Well, of course, my initial response is maybe a pandemic, but more often than not, it's trauma. You know, I can recall a client that we served who was a police officer in Atlanta and didn't remember how he got to Chicago. But his wife and his daughter died in a tragic incident. And so he was never the same again. And so more often than not, it's a traumatic experience that causes, a crisis event.
And can you describe the typical person, just so people, you're from Chicago, you've got this service, can you, just to help people in the room understand this a little bit more, who's the typical person that guys at C4 are serving?
So at C4, it's not the traditional, you lie on the couch and you tell someone about your problems. This is blue-collar social work. And so let's take, for example, I'll call her Mrs. Jones. So Mrs. Jones would be high acuity, paranoid schizophrenic with suicide ideations. So that individual needs a higher level of care. So we'll have case management services for her. We'll have, and in these case management services, we will ensure that she's holistically taken care of. And so, because one of the things about it, if Ms. Jones is not on her psychotropic medication, she's not taking any of her other medications. So we have to wrap around her a full level of support to ensure that she's taken care of. And then, of course, we would have community-based services for her. We meet her where she's at. She would have outpatient services available for her. So we are boots on the ground, blue-collar social work.
And has it gotten, during the pandemic, and if we want to call this sort of quasi-post-pandemic era, has it gotten harder for Mrs. Jones to get services at C4 and also more largely in Chicago?
Exponentially so. So Illinois historically has been 6th in population, but 28th in access to care, and 32nd in the ratio of budget spent on mental health care. Now, recently we've made huge investments into healthcare and, more importantly, behavioral health. However, the infrastructure is just not there. And so wait lists are through the roof. Imagine being someone who calls a crisis hotline and it is determined that you need permanent supports or inpatient care, but neither are there. They tell you to call this organization for outpatient therapy, but their wait list is 45 to 60 days. Or they say, you need inpatient care. And I've literally seen youth stay in hospitals in the emergency room for 45 days because there are not enough inpatient units available.
I know people heard that, but just say that one more time about the 45 days and the kid.
Yeah, so imagine, how many have children in the room? Imagine your young one being in a crisis. Previously you would Google trying to find a number, who to call. You find a number, they send you to this hospital, and you go to the hospital, and of course you have to wait hours sometimes, and then they do the assessment, they determine that you need inpatient care, so your child needs to be admitted. And then they're calling around as you wait to try to find a bed. Lurie Children's Hospital in Chicago has 60 plus days wait for a bed.
Thank you. And I just, there are moments to underline, and this is one of those moments, because to put this into a little bit more context, when we talk about 988, yes, it's a crisis line, but it's a crisis line that a lot of times people will call a front door, right? I know a lot of you guys have heard this front door image, but it's a front door to what? And when we talk about a crisis that is being resolved in 45 days, that's laughable. So this is just a moment to highlight, a front door to what? And is it a front door to something that we want? Or is it a front door to something that is not adequate yet? And I think when you talk about a 45-day wait list, it's very clear it is not adequate. So moving on, thank you for that, Carrie. And that's sort of dive deeper into the 988 stuff so people can get a sense of you on the ground, C4. To prepare for 988, you guys bought a van named, I love this, Van Diesel. There's a bit more money in the pipeline now. In theory, at its best, what can you and your staff now do for people in the community you could not do before 988?
So I alluded to Googling for a number, which, if you're in the middle of the crisis yourself, that's not what you're doing, right? But if you're calling for someone else, now you have an easy number to remember, right? And then if you're actually in the crisis, let's take Ms. Jones, for example. Previously, anybody ever been pulled over by the police? How do you feel when you see those lights behind you, right? That's the exact opposite of what you need when you're in the middle of a crisis. And so we bought a van, and instead of putting anything stigmatizing on the van, we put hope on the side of the van. So that when you show up in a crisis event, because a crisis event can happen anywhere. If you're in a Target and your best friend is in a crisis, instead of trying to find who to call, you dial 988 and imagine how you feel with a van that says hope on the side that shows up. We can take you out of the glaring eye of the public, put you in a therapeutically sound, mobile, clinical environment, and de-escalate, give you the support you need, and then find the permanent support you need.
That's part of the vision. That's part of the goal. Mm-hmm. When you think about the two, we practice this. What are the two biggest hurdles, aside from staffing, which we're going to talk about with Emily, that are making it hard for you at C4 to realize this vision of delivering hope to people in crisis?
It's the silos and infrastructure. In community behavioral health, you have to follow the money. And so you may get funds from the state, you may get funds from the federal government, county, and then the city. With 911, we have laid out an infrastructure so those things work together. But that's not what has happened in 988. And so we need that investment beyond funding so that those different levels of the government and entities work together in a congruent way so that we can deliver these services. And then I alluded to infrastructure earlier. We expect increased volume from 988, but what happens after you dial 988, especially if you're waiting, a significant amount of time for the stabilizing support you need? Answering a crisis call is just the first step. Then we determine if you need a response. The crisis continuum starts with the call. Then we have to determine what level of response. We can de-escalate sometimes over the phone, but if we need to go there, then we have Van Diesel, and we can show up on the spot. But the third level is what happens if you need permanent supports and the wait lists are gone through the roof, or what happens if you need inpatient care. So that's what really, really needs to happen next.
And so you and I have had this conversation a little bit. A dream budget. What how much more money do you think you need, and what would you do if you had that money? And I know one of the first answer you gave me when we talked about this was I'd raise the salaries for my staff. But beyond that, though, what would you do in terms of the services? Where would you direct that? How would this money be spent, and why do you think that would be a good use of money?
Well, I'll give that answer anyway, if you don't mind, because I think people need to realize that firemen aren't paid based on the number of fires they put out. They're paid based on the trauma that they could potentially experience, how dangerous their job is. Police officers aren't paid by how many calls they answer. But for some reason, my staff, we quantify what they do by how many calls they answer, which is not fair. And so the first thing I would do is pay them as the first responders, as the heroes that they are. But also, if I could, I'd have a fleet of Van Diesels, so to speak. I would have one vehicle with hope, another vehicle with healing, another vehicle with inspiration, so that we can meet the growing need. What the pandemic made us realize is that none of us are truly okay. We all need additional levels of support, but we have to make the appropriate levels of investment in that support. My grandmother used to tell me that you can always tell what's important to a person by where they spend their money and where they spend their time. Well, it's time as a country that we put our money where our mouth is.
We have 56 seconds. That's sort of the mic drop moment. I don't really feel like I've got much more I want to say to that. One quick question the news person in me wants to know. So 988 has been up and going for a couple of days now. What have you all seen at C4?
We've seen a slight uptick, but as I mentioned, because the infrastructure is not there and the system is still siloed, we hadn't really seen the uptick that we thought we would see. My clinicians have been doing this for a couple of decades, so they're ready, and they can do this. I won't say they're asleep, but they can do this seamlessly, and we're prepared for the volume. But I don't think the infrastructure's there just yet.
Okay, very good, thank you, and we managed to nail that on time exactly, which is amazing, especially after I went over on the introduction. Okay, so. Audience question to you all, and this is a moment, this is not a poll, this is actually asking for a story if somebody in the room is willing to share that story, and if you're not, that's fine. Has anyone in the room or someone you know called 911 for a mental health crisis or behavioral crisis, and it didn't go the way you expected? There are people with microphones walking around, and if somebody raise their hand here in the middle, I think. And if you'd please stand up and, oh, that didn't happen, okay. Anybody? All right. You have one. Let me just try real quick a backup for the crowd, but does anyone in the room feel like they have concern about calling 911 because you do not want law enforcement to show up? Would you be willing to talk about that? Okay, great. And when you stand up, introduce yourself, please.
Hi, I'm Sinead. I work at the Association of American Medical Colleges in their Office of Government Relations. I live in DC, and sometimes I see people who are having a behavioral health condition, and I'm concerned, but I also feel like if I were to call the police, what if they were stigmatized by, the color of their skin, and would I be culpable? I think that I would hold myself responsible for an adverse outcome. And so that prevents me from making that call. And I think that, walking down 14th Street, I think a lot of people have that same thought of maybe having concern, but also not wanting to activate a system that is inherently biased.
Thanks for saying that. Anything any of you guys want to say to that in response?
Yes.
Go ahead.
So I don't know if you all remember a gentleman by the name of Laquan McDonald. It was highly publicized. My directors called him one of their kiddos. So he actually was a crisis call that C4 had handled before. But 911 was called, and it ended with this gentleman being shot 16 times by the police. And so those are the types of, police interactions that 988 can forego. Now, we're doing a pretty good job in Chicago at training police. We have a full CIT division where we work intimately with the police, teach them how to engage with those who are having a mental health crisis. But if you can avoid those opportunities and de-escalate and call a mental health professional, you wouldn't want, you want the right tool for the job. And so we are the right tool for the job.
Very good. Does anybody else have any story or something that they want to share about a 911 call gone not the way you wanted, or an interaction, like why 988 could be a good thing in terms of diverting law enforcement away? And again, stand up please and introduce yourself.
Molly Burrich, Otsuka Pharmaceuticals. I think that part of the consideration we have to think with 988, hopefully we move on from a place of where we are now with crisis service to mental health is as important, if not more important, as any other physical health condition. You don't send the police to someone in diabetic crisis or cardiovascular crisis. So I think 988 hopefully can help to serve as a foundation for addressing mental health with the right tools, as you noted, and the right types of professionals, as you would any other health condition.
Great, thank you very much. We got 30 seconds. All right, yes, sir.
I'm here. Francisco Semio with MedStar Health. Would like to share is that there was an exact situation where a friend of mine, elementary school, high school, called me, didn't want to call 911, but flat out said, I think I'm going to hurt myself. But he didn't want to call 911. We grew up in the neighborhood. Unfortunately, within the past 6 months, he had an incident with the police because he had lost everything, and his anxiety level was so high. So that stop just turned out to be very bad, and then he didn't show up because he had anxiety about what would happen. So there was a warrant out for him, so he did not want to call 911, and he didn't know who to call, and he was literally about to hurt himself, and it was wee hours in the morning. I had to physically go pick him up and take him to the emergency room. So I'm praying that this new hotline is going to do something good.
And how is he?
He's still dealing with substance abuse, but we brought in friends from the high school, so we're trying to figure out, how to best help him out. Luckily, I work for MedStar Health. We do have a behavioral health unit, so we're just trying to. It's on him now, and he's missed a couple of appointments. But we're, as a group, as fellow alumni, we're trying to do our best.
Really lucky he has you as a friend. Thanks very much for sharing that. Appreciate that very, very much. All right. So, move on to you. Thanks for everybody. Really appreciate we're trying this engagement thing. I appreciate you giving it a go. Emily, if you would just introduce yourself, please.
Sure. Emily Bloom. That was loud. Emily Bloom. I'm the Chief Executive Officer at Foundation 2 Crisis Services, headquartered in Cedar Rapids, Iowa.
And so, Emily, this past year, your organization has had over 80,000 crisis contacts. How much do you expect that number to grow now that 988 has gone live, both in the short term, these first days when very few people have actually heard of 988, and in the long term?
We're expecting to take about 50,000 additional contacts in the next 12 months, and I assume with ongoing marketing that will increase. And on Saturday, when 988 went live, we had about double the call volume that we would have on a normal Saturday.
And to meet demand, you need people. Your organization is about 150 people strong. And you said you've been trying to add staff. How many? And what steps have you taken to try to do that?
So we are trying to add about 25 crisis counselors. In the 6 months leading up to the launch of 988, we did 2 base pay increases, which was a total of about 25%. We also have really focused on benefits, things that are small cost to our agency, but a large cost or a large benefit to our employees. So we've added 2 weeks of paid parental leave. We've added pet insurance, which you think wouldn't matter, but holy cow, people came out of the woodwork for pet insurance. None of our teams starts with less than 4 weeks a year of PTO, flexible scheduling, letting people work from home. I basically went to our team and said, what ideas do you have? Essentially, we'll do anything to recruit people, which is how we ended up with pet insurance.
And so I know you're also talking with state officials about changing qualifications. Right now, who is eligible to do this job, and how are you trying to get the state to change the qualifications?
So Iowa is similar to other states where there is either expectations in code or some accrediting body says you have to have a certain level of education and experience to do this work. And our goal is to keep the quality of service high while being able to recruit people that might not meet that standard. So for example, if we had someone who had great lived experience and had volunteered on a crisis line for 3 years, they would not be eligible under our state code. But then we've been asking for exceptions to policy to say, hey, what do we need to do? More training, whatever, to just make sure that they're a good fit for the work. Someone with a bachelor's degree and 2 years of experience might not be a good fit if they don't have any empathy. And so how do we kind of find the perfect combination?
And are you having much success making that argument at the state level?
Yes. So I feel like Iowa officials have been really supportive of understanding the crunch. I mean, even though 988 is a federal mandate, our state needs to get behind it and support it. So they're not only giving us some blanket exceptions to policy, but also on a case-by-case basis. And that has been helpful. It hasn't solved my workforce issues, but it has been helpful.
And on this workforce issue stuff, like what headwinds have you faced? How far along are you in this march to hire 25 people?
So I have 10 of 25 hired. The headwinds I've faced, well, there's 2. One of them is about money. I know the cost of living in Iowa is lower than other areas, but our team starts at $17.50 an hour. And I'm competing with retail places like Target. I lost an employee to AirFX, which is a trampoline park. And I was like, how did this happen? But then I realized I know exactly how this happened. It happened because being a cashier is much easier than answering crisis calls. So I get it, and I probably would have made the same decision if I were in their shoes. Because that's the other piece of this about the difficulty of the work. So my teams work 8, 10, 12-hour shifts, and they never know what is on the other end of a line when they pick it up. So it could be someone who wants a referral for a clinician in their town. Okay, that's not a long call, not a super draining call. We're going to get the caller what they need. And then I have calls where there's someone sitting at home with a loaded weapon beside them who is so seriously contemplating suicide that it is taking a significant amount of time and effort to keep that person alive. So the dilemma that I have is, what do I pay someone who saves lives for a living? Like, what is that? What is that person worthy of making per hour? And the answer is like I don't have enough money to pay people what they're worth. And as a CEO, it's a really heartbreaking place to be, because I know my people are worth more than what I pay them. And the amount of money that I have to pay them to do this work and to meet contract demands is absolutely insufficient.
You said that last year your team saved the lives of 300 people. I've been reporting on 988 for like 8 months now or whatever, but I don't quite, and I don't know, maybe people in the room do know what that means, save somebody's life, but can you just take a second to really put a fine point on the work? What does it mean when you say save someone's life? You saved 300 lives.
Yeah, so I'm sure we saved many more lives than that. One of the difficulties of doing this work is you don't always know what happens after a call ends. So my team could take a call and that person could go die by suicide, and my team could take a call and that call could have been absolutely transformative in their lives. And that person went on to be connected to resources and have a really good quality of life. But an active rescue is when someone has already taken an active step to end their life. Maybe they've overdosed and they called a crisis line looking for support. And we were able to send rescue, and we were able to keep them alive and give them an opportunity to connect with life the next day and try again.
It sounds like, to start with 988 at least, you are short-staffed. You, putting it mildly.
Keeps me up at night.
Yes, indeed. To give people in the room a sense, can you share an anecdote? Like, what has happened in the past to the quality of crisis services when you guys were answering the 1-800 lifeline, suicide prevention lifeline? What has happened to the quality of crisis services when you were short-staffed?
So people don't get what they need. It's possible that someone might have to wait longer than what they should have to wait to get crisis support. I also think there's a staffing piece of this where, as my team is watching our queue fill up and they're short-staffed, they're probably not giving every caller the time and effort that they deserve. They might be rushing them off the line faster than really what that person might need. And so there's a quality piece that way. But the other piece is also what I care about as our CEO, which is that our people, when they are taking back-to-back calls without opportunities to decompress themselves, to make sure that they feel, restored between calls, that they get to show up as their best self, that impacts quality as well. And that also leads to burnout. And that also leads to this staffing issue that I'm in, is that it's really hard to do this work for long periods of time, many years, without just absolutely getting burnt out and deciding that you want to go be a cashier at a trampoline park.
And one contextual point that we've done in our reporting on this, there's some 200 crisis centers that are being staffed up for 988, and the majority of them are short-staffed right now. And so when you give your answer about people burning out, people not getting adequate services, this is not just happening in Iowa.
No.
This is a problem. There are not enough people in these jobs right now. So how the country, and really the way Congress has set this up for right now, this is really on states to figure out the funding, to figure out the staffing. And it seems like your experience is indicative of what many of your colleagues around the country are facing.
Oh, absolutely. I'm on a lot of national work groups. I'm on the National Suicide Prevention Lifeline Steering Committee. My experience is not unique.
Quick, we've got 30 seconds here. What's one thing you would like the DC crowd to remember about what you're saying today, Emily?
Well, I'm a rule breaker, so I'm going to give you two things. One of them is that 988 is absolutely a brilliant concept, but it is a logistical nightmare. And if we don't adequately and sustainably fund it, if we don't give the crisis teams that are doing this work the tools they need to be successful, it will not be successful and it will fail. And which leads me to my second point, is that people will die. And it is, are you going to cut me off?
Not at that line.
This may be the one chance that we have to help someone. What if it's the very first time they have ever called a crisis line? We shouldn't make them wait. They are worthy of our time and effort. That is where I'll stop.
Thank you very much. So we're gonna, well, yeah, I don't know what you're gonna say, but that's great. No, cool. Yeah. Break with format here.
Good morning. My name is Andrew Kessler. I work here in Washington on mental health and substance use policy, and my specialty is workforce. So, Emily, I'm going to put you on the spot with all respect for what you do. Before, our host asked us how many people work here in influencing policy, and a lot of hands went up. So there's a lot of people here who can help you. So my first question is, who exactly funds your center? Is it grant funded? Is it a contract from the state? And this, because if it's grant funded and the state or federal government has a role in it, and we say to them, $17.50 an hour isn't enough, the first question we're going to get back is, well, what is? And when you were talking about fees, you were kind of like, well, I don't know, but the market's important. And to compete with Target, to compete with the trampoline park, but without going up to $50 an hour, looking at the market, looking at the qualifications, looking at the difficulty of the work, which we all appreciate, I'd like an answer as to what you think is a good number, because that is an argument we can make to policymakers to say, when we need this funding, this is what this job is worth, and we need to keep the qualified people in these positions. So I'd like a little more of a specific answer if possible.
That's great.
So our center is funded in a variety of ways. We have the contract for the statewide crisis line, which is some federal dollars that trickle down to the state. One of the difficulties with 988 is that the federal government left it up to states to fund, and states have done that in a variety of ways. So there, I think, are 5 states who have been successful in being able to do a cell phone tax or fee similar to a 911 tax or fee. If Iowa did that at the cents that I recommended, it would put $33 million into crisis services, not just to us, but we're the entry, but to mobile crisis teams, to law enforcement liaisons, to crisis stabilization and crisis observation. I would say that $25 to $30 an hour would allow me to recruit people who would be willing to stay and do the work. I mean, I can't tell you why I came up with that number. One of the challenges with that, though, is that if I do that to crisis counselors, then they're making more than my current supervisors. And so there's this trickle-up effect from a supervisor to a program coordinator to a program manager. And so the funding has to be able to cover more than just those positions of the people doing the work. It has to be a kind of a chunk of money that we can figure out how to, put across workforce.
Thanks so much for that question. Yes, sir.
Eric Scharf with the Depression Bipolar Support Alliance here in DC. I heard you talk about different levels of qualifications of staff. I didn't really hear you talk about the role of certified peer support specialists and peer support workers. I was wondering if you could address how you incorporate those people who often don't have the kind of bachelor levels. I heard you talk about bachelor levels, kind of training, how you incorporate or see those kind of folks working in this area. We love 988, by the way.
Sure. So in Iowa, you can be a certified peer support specialist, and you don't have to have the same education and experience requirements. You have to, have your lived experience plus do a certain amount of training. We absolutely hire peer support specialists. What I have found is that a lot of them actually like to work on the warm line more than they like to work on the crisis line, which isn't a service array that our agency provides, but they actually end up taking a lot of the qualified peer support specialists to work on a different service array.
quickly, our therapeutic model for Van Diesel is that we will have one licensed clinician and one peer support specialist. And the reason why is we want someone from the cultural environment that that person is in to meet the need. Someone who stays in the north part of Chicago may have a completely different experience than someone who stays on the west side of Chicago. So we want to be culturally sensitive and bring someone with lived experience to the event as well.
Great, thanks. We are going to move to our third and final one-on-one. Andrea, if you would introduce yourself, please.
My name is Andrea Harris, and I'm a Helpline Specialist at First Choice Services. I answer the 988 line.
And how are you feeling about being up here?
I'm very honored and also terrified.
And what you and I are going to talk about right now is Andrea has a lived experience, and you get your own mic. Super nice. Andrea, you have a lived experience, and we're going to walk through a story. And the context here is we're talking about this crisis line. Well, what does a crisis look like in real time? What does it mean? What would it mean for someone to have 988? And it's those questions that I'm hoping to frame this conversation that we're about to have. So, one morning in June of 2012, paramedics woke you up with Narcan. You'd been struggling with heroin for a while, but that morning you woke up asking yourself questions like, am I going to get arrested, and where am I going to get my next high? But a new question popped into your mind too. What was that?
Did I want to continue to live this way? Did I want to suffer any longer? And the answer to that was no.
And what happened that day for you as you debated whether to commit suicide? Tell us about that day.
The day was chaos, and also determination. I felt like I had found a solution to what seemed like a lifelong problem. I really just wandered around that day. I didn't allow myself to process the thought entirely because I would have had to think about my children then.
Just hold it up.
Okay, awesome. So that would have required me to consider my children in that equation, and that was something I was desperately trying to avoid.
Where were your kids right then?
They were at school in that moment. When I woke up that day, they were in school. I had overdosed in the alley behind their house. So I knew when they got on the bus that afternoon or when they got home from school that day, the entire neighborhood would be talking about how their mom had been found in the alley of overdose again. And I did not want to have to face that, I think. I didn't want them to have to, but I knew that they would. I wanted to avoid it.
And the kids had been, the way you put it when we first talked, you said that the kids had been at a sleepover that they never came back from. How long had they been away from you at that point?
You know, honestly, I wish I could put a number to that, and it's virtually impossible because that time period all runs together, but it was months that I lived around the corner from my children and did not see them, allowed someone else, a stranger, mind you, someone I didn't even know, to care for them because I believed they were better off there, and they were. What was I going to do, take them to the local abandoned house with me? But they needed their mom, and I was not capable in that moment of being there for them the way that they needed me to be.
And you had made a promise to yourself that you were never going to commit suicide, but on this day in June of 2012, you changed your mind. You thought it was a good idea. You thought you were going to do it. Why had you made that promise to yourself that you were not going to commit suicide up until that day?
My mother committed suicide when I was 12, and I carried the weight of that my entire life. You know, when you're that young, you believe, if I had been a better kid, if I had done something different, better, anything, things would have been different. I always believed that my mother committed suicide to get away from me, to get away from us, her family, her children. And I swore that I would never do to my children what my mother did to me.
So why did you on this day change your mind?
I was tired of suffering. I was tired of existing in the state, an animalistic state almost that I was in. It was terrible.
That night, you felt like you'd made the choice. You were in the abandoned house. What happened?
I now know what I did that night was play the tape through. That's something you learn in substance use disorder recovery. I didn't know it at the time. I was just kind of playing it through, and I have a sister who is the literal definition of perfection. She is the kindest, most compassionate, most loving person that has ever or probably will ever exist. And she is my only family. So I knew if something happened to me by choice or not, my sister would step up and she would take my children. Sorry. She could give them a life that I didn't believe I would ever be capable of giving them financially. Just the way that her life looked was not something I believed was possible for someone like me. And following that thought was the thought that they would be better off without me. I was the one that was causing harm to their lives. And it was also in that moment that I understood for the first time why my mom did what she did. She believed that we would be better off without her. That was not true. And I understood that my children would not be better off without me. I didn't want them to carry the weight of what I'd carried my whole life. It would just be passing it to them, and they didn't deserve that. And I had something that my mom didn't have, and that was the knowledge of what it would do to the people that loved me that would be left behind. So I'm still here.
And that night, two things happened. You made the decision not to harm yourself, and you also understood for the first time your mother's motivation, and you were able to forgive your mother.
Completely, 100% able to forgive her. And I didn't even realize that I needed to forgive her. I didn't even realize it was something I was holding against her. But it was such a resentment that I had that I wouldn't even let myself think about, because I felt guilty for it, for that anger and that resentment that I carried. And yeah, immediate, complete forgiveness. That moment allows me to forgive my husband, because my children did not have to suffer my loss, but they did have to suffer the loss of their dad, who completed suicide 5 years ago. So I never dreamed that I would be in a position to use my mom's suicide to help my children through their dads. It's not fair. I'm sorry. It's not fair. And it's a tragic thing that happened to an amazing person who did not see any other way out. But I was here to hold their hand through the whole thing. I got clean when my husband died. I went to treatment and I got my life together. And I have been present in their lives every moment since that one.
Final question, Andrea. Your experience that day captures one way a crisis can play out for someone. It can be a total surprise, and it can come fast. Could you have used 988 that night in that abandoned house in June of 2012?
Absolutely. What I would not have given for a line like that. I was not calling 911 under any circumstances. I did not want a sudden police presence. I was a IV heroin addict at that time. There's absolutely no way I would consider calling 911. I called 911 about a year before my husband completed suicide for his mental health crisis, and he went to jail. So no, I would never call 911. I would have given just about anything for a number like 988 for myself and for him, really for him. I think it would have, it may not have changed the outcome, but it would have certainly changed his journey. Just someone to hold his hand, because I couldn't. I wanted to, but that's not what he needed from me. He didn't need me to be his crisis counselor, but he needed that, and he just didn't have access to it.
Thank you. Thank you very much for sharing your story. And before we go to audience questions, I just want us to give a hand to this incredible group of people here. We've got I don't actually know what time we have. We've got 5 minutes. Okay, so we got time for a couple questions. We've got a question up here in the front, and again, if people could just introduce themselves, and if you have a specific person that you want to ask, just direct it to them.
Hi, my name is Magda Kowalzikowski. I'm a family medicine doctor. I'm just curious, anyone can answer this. Is there a chance if you call 988 that at some point police could get involved, or is there a sharp line between that and they never get called? I'm just curious. Thank you.
Well, I talked about the crisis continuum, and so during that initial call, when you do your assessment, you determine what the second step is and the level of response needed. So if the person is violent, then we would need to still engage the police. But, with the funding that has been added to 988, there being more police trained, and oftentimes, believe it or not, the police have called us to assist if we can de-escalate and work with them. So we're hoping it evolves to a level of tandem in those opportunities.
Yeah, I would just say that with 911, police is the first response. With 988, it would be the last resort. And every state has different crisis services that are available, and even like in Iowa, rural communities maybe have less resources available than urban communities, but the goal is to provide someone the safest, least restrictive level of care. And so with 988, we know on average about 87% of calls are managed over the phone. I mean, it's a pretty high percentage, so it's a much better place to start than by calling 911, where you know that the first course of action is that police will go, which feels like overkill is not the right word, but often that's just not necessary and not what's best.
Is there anything you want to add?
No, I agree completely. There are situations where we have callers that we do have to contact 911. It's always done with their permission. A lot of calls are transferred to us directly from 911, or they say, that I had an interaction with the police and they gave me this number. And that's pretty common. It's not common that it has to be escalated, at least not in my experience, in my area.
Got a couple more questions.
Hi.
Person in the cap back here.
Oh,
Oh, I'm sorry.
no, you're
Sorry.
good.
Yeah, you should see the green jacket. It's a nice jacket.
Hi, my name is Pooja. Thank you all so much for your insights and your time this morning. And Andrea, thank you for being here. The world is a better place because you are. My question is a follow-up, really, to this one. So, I've been seeing a lot of inaccurate to harmful information regarding 988 circulating on social media, especially as it involves the response of law enforcement, or I've seen things saying that you're gonna get directly involuntarily committed, which is just not true. How can we tailor messaging efforts to be able to accurately describe what you just said for people who are not in this room, who are not involved in the mental health policy, who don't really understand the nuances of a continuum of care or something like that, to give people the accurate facts, but without inaccurate fear-mongering?
Well, one of the most frustrating things that I've seen is that, 988 is the new 911, which in theory I understand, but we've had a really hard time with people then assuming that a mental health counselor is coming to you. You call 911 and someone comes to you, and there's this kind of misunderstanding that also happens with 988, which isn't the case. And so I think one of the things that's important to note is that anytime you call 988, you're going to get a trained crisis counselor who is going to do their best to meet your needs and figure out the next course of action, for you. And there's so many different services that is, which is why kind of pigeonholing us into when you call, you get X, and then you get this, and then it's involuntary or whatever. It's just much easier to say it's a first point of entry to a supportive system that can provide some adequate response, and then from there figure out what next steps are.
We're at time here, but one thing, as somebody who's had to try to think about messaging and framing this information, what I think is the most fair way to talk about it in the simplest way is to say it's a front door to care. And there is this crisis care continuum, which has 3 steps. There's calls, which 80% of these calls are handled via phone or text or chat. And then people can come to you. That's the next step. Or you can be taken to get additional services. So that's the kind of idea, a front door to what? A front door to a phone call, a front door to somebody coming to you, a front door to getting you additional services in the community or in the facility. But then how law enforcement is involved is going to change community to community. There are a lot of unanswered questions. There's a lot of unknowns right now. We need to remember that, and we need to be honest about that. And people are going to handle it very differently. And if we try to pigeonhole this as painting one size brush or how it should be, that is contributing to the misinformation out there. The most accurate thing to say is it's a bit of a mess, and it's very different from community to community. That's where we are right now. That's the starting point, and that's just the truth about 988 today. I know we're over at 1.5. I really apologize for that. As a radio reporter, that's bad. So thank you all very much. You've been a wonderful audience. You guys really did participate in this in a beautiful, beautiful way. And one more time for this panel, let's give it up.